Welcome to Advanced Practice, where we brew together the latest thinking in mental health practice. This content is for educational purposes only and does not constitute medical advice, diagnosis, or a prescription. Clinical decisions should be based on individual patient assessment and established professional guidelines. This is a bonus section on antipsychotics. Today, we are going to unpack one of the most clinically relevant questions in psychiatry. How much antipsychotic medication is enough? This video reviews clinical implications from the article Dose Response Meta-Analysis of Antipsychotic Drugs for Acute Schizophrenia, published in the American Journal of Psychiatry, which examined randomized controlled trial data to clarify how antipsychotic dose relates to efficacy and tolerability. Across antipsychotics, the dose-response curve is not linear. It climbs, reaches a therapeutic plateau, and then flattens. After that point, increasing the dose mostly increases side effects, not efficacy. The key message for clinicians is this: most antipsychotics reach their optimal therapeutic effect at moderate doses, and escalating beyond that range rarely improves outcomes but reliably increases side effects. Let's translate that into actual prescribing ranges. Take risperidone. Symptom improvement rises steadily up to about 4 to 6 milligrams per day. Once you go beyond 6 milligrams, the antipsychotic benefit largely plateaus. What does not plateau? Extrapyramidal symptoms and prolactin elevation. Those continue to climb. Olanzapine follows a similar pattern. Most of its efficacy is achieved between 10 and 15 milligrams per day. You can go up to 20 milligrams for positive symptoms, but beyond that, you see minimal additional improvement. What you do see is more weight gain, more metabolic burden, and more sedation. Higher dosing does not rescue negative symptoms. In many cases, it worsens apathy through sedation alone. Quetiapine clusters in the 400 to 800 milligram range for antipsychotic efficacy. Below that range, dopamine blockade is often insufficient for robust psychosis control. Above that range, tolerability declines, but symptom reduction does not reliably improve. Aripiprazole is another example of the plateau effect. The dose-response curve levels off between 10 and 15 milligrams per day. Increasing beyond 20 to 30 milligrams rarely improves psychosis. It does, however, increase akathisia and subjective restlessness. The long-acting formulations reflect the same principle. Standard therapeutic dosing works for most patients, and escalation beyond that range rarely transforms outcomes. Ziprasidone tends to be optimized between 120 and 160 milligrams per day, taken with adequate food. Going higher does not consistently improve efficacy and may worsen QTc risk and tolerability. Haloperidol is even more straightforward. Most antipsychotic effect occurs at 5 to 10 milligrams per day. Above that, extrapyramidal symptoms rise sharply, while additional symptom reduction is minimal. Now let's shift to negative symptoms, where dose precision becomes even more critical. Olanzapine shows modest benefit for negative symptoms at 10 to 15 milligrams per day. Higher doses do not enhance that effect and may actually blunt motivation further through sedation and metabolic impact. Azenapine appears optimal at 10 to 20 milligrams per day. Higher doses increase akathisia and oral hyposthesia without improving negative symptoms. Brexpiprazole has a narrow therapeutic window at 2 to 4 milligrams per day for both positive and negative symptoms. About 4 milligrams, side effects increase without clear gains. Below that range, dosing may be subtherapeutic. Cariprazine stands out for negative symptoms, with strongest evidence in the 1.5 to 3 milligram range. Escalating above 4.5 to 6 milligrams increases akathisia, but does not improve negative symptom control. Iloperidone reaches efficacy for positive symptoms at 12 to 24 milligrams per day, titrated slowly because of orthostasis. Higher doses worsen tolerability without superior outcomes. And then there is clozapine. In treatment-resistant schizophrenia, efficacy typically emerges at plasma levels corresponding to roughly 300 to 450 milligrams per day, depending on metabolism. Doses above 600 milligrams rarely add meaningful efficacy, but they significantly increase seizure risk, sedation, and metabolic burden. Even with clozapine, more is not automatically better. When researchers convert doses into chlorpromazine equivalents, most antipsychotic efficacy across agents clusters between 300 and 600 milligrams per day. Beyond that window, the curve flattens. Side effects continue to rise, efficacy does not. The modern goal in schizophrenia treatment is not maximal dopamine blockade. It is precision dosing, finding the dose that controls symptoms, preserves function, and minimizes long-term harm. So that's for this antipsychotic series. Thank you for watching. Till next time.